الحقيقة قبل ما ابتدي تحية إعزاز وتقدير الأستاذ الدكتور أشرف حاتم والمجموعة المنظمة، والقصر العيني ده ليه معزة أولى وخاصة عندي، لأن هي دي المدرسة اللي أنا ابتديت فيها كطالب وكطبيب امتياز وكنايب اسم الصدر، واللي بعد كده برضو الدبلومة، وبعد كده لما رحت عين شمس وبرضو عملت الدكتوراه، والدكتوراه كانت في القصر العيني برضو، وريليتد للموضوع المحاضرة بتاعت النهاردة. وأستاذنا الدكتور عبد العزيز سامي الحقيقة اللي هو أوجد هذا التخصص، كان أول رسالة دكتوراه في مصر على البلمونري فانكشن، أول سبيرومتر جه لاسم في القصر العيني. وتفضل عليا الدكتور عبد الحكيم ان ادانا الاوضه بتاعته اللي هي الاوضه بتاعت اللي انتوا عاملينها بالمونري فانكشن، حطيت فيها اول سبيرومتر، كان قبل كده بالدرام السوداء وبتشتغل وكده، وابتديت اشتغل فيها. وايفن حتى يعني اشتغلت فتره مدير القصر العيني، لان لما قامت الثوره وجابوا واحد ضابط وحطوه مدير، الاثنين مديرين الدكتور عوده والدكتور عطارد اصلهم تراكوة قعدوا في البيت. قال لي تعالى، وقعدت فتره حوالي اسبوعين ثلاثه ادير القصر العيني، بالرغم ان انا نايب في اسم الصدر عند الدكتور عبد العزيز سامي. مش عايز اطول في هذا الكلام. الحقيقه الكوميونيكيشن بتاعتي النهارده انا هتكلم على ازمه in the elderly individual، وانا بعتبر الالدرلي individual ده ماي بارتنر، والالدرلي individual ده يعني ماي اتيتيود، ان الالدرلي individual need our enforcement و our enforcement while managing him. ما فيش شك ان الايجينج بروسيس is a natural condition، والelderly individuals are increasing worldwide due to better sanitation, the control of epidemics and pandemics, use of antibiotics for infection, with civilization. الage average age بتاع individuals بيزيد في more in the developed countries عن developing countries. وكان زمان احنا ما كنا نواب ولا كده كان استاذ عنده 50 سنه، او في الجورنال يقول لك رجل كهل اللي عنده 50 سنه. دلوقتي in many countries الافريج age is above 70. الحقيقه لو قلت مقدمه تاريخيه بسيطه، يعني مش موضوعي كله تاريخ، لان انا يعني بجانب الطب ماي سبيشاليتي الاولانيه والاخرانيه بعد ما بطلت براكتس هو التاريخ، لأن أنا أمين الجمعية المصرية للآثار والثقافة التاريخية اللي كلهم بتوع آثار وتاريخ، وأنا في وسطهم ميديكال مان. والتاريخ الطب الحقيقة يعني very important، جزء من الاعتزاز بالقومية بتاع الواحد والهوية بتاعته، إن يعرف تاريخ. even يعني كان زمان لما يجوا يمتحنوا دكتور كان يقول لك تسأله عن تاريخ الطب، إذا كان لا يعرفه فلا داعي لأن تسأله عن أحوال المرضى. يعني he should know the past history بتاع التاريخ. الأزمة حقيقة برونكيال أزمة is old as man himself. القدماء المصريين عندنا مين للبابايراي، الاوراق البرديات، هو مش عايز ادخل في تفاصيل قوي، المين 7 برديات الرئيسيه ادوين سويس وإبرز بابايرس وخلافه. انما يعني in this papyri they speak about the causes of the diseases. اول سبب external causes، وترجمتها بالعربي لما شفتها في إبرز بابايرس يقول له أصابته ريح هواء فاسد، يعني اللي هي air pollution. flooding of the Nile والعطانة اللي بتحصل، الانسكس بايتس الحشرات، يقول لك في internal causes وفي سحر. واستاذنا البول غاليونج اللي هو حجة في تاريخ الطب مؤلف كتاب كامل طب وسحر في عند قدماء المصريين، وفي يعني punishment of the gods يعني و unknown causes. الحقيقة يعني لما جينا لقيت في إبرز بابايرس بيتكلموا على البرونكيال أزمة إن ديتيل زي ما احنا بنعرفها دلوقتي، مفيش حاجة زيادة. في الأوبزرفيشن من 326 ل 335 بيوصف الهيستوري ازاي تاخده من العيان، الانتروجيشن مع العيان، الاكزامينيشن. لاحظوا يا جماعه ان قدماء المصريين كان عندهم انسبكشن وبالبيشن وبركشن زي ما عندنا دلوقتي. ايفن قريب لقيت استاذ الماني كاتب لا يا جماعه دول بيعرفوا زي نو اولسو اوسكالتيشن، لانه جايب صوره بتاع واحد والدكتور بوت هيز اي على صدره، فبيقول ايفن زي نو زي اوسكالتيشن. ف يعني الازمه is old as man himself، وكانت معروفه عند قدماء المصريين and they can know even the prognosis. يعني كان يقول لك have asthma or other disease, this patient I am going is going to be treated and get healthy. This I am going to treat. This is going to die. I am not going to treat him. لما دورت بيقول ليه going to die، قال لك a patient عنده pain in the stomach referred to the shoulders to his hand is going to die. يعني coronary artery disease يعني ذبحة صدرية. مش عايز اخش في تفاصيل، انا بس في يمكن في ناحية تانية، انما عايز اقول لك ان ده موجود. لو تتبعت في التاريخ هتلاقي في تاريخ الطب الإسلامي أبو بكر الرازي، وباعتراف العالم الغربي the best clinician in the world لغاية دلوقتي. جامعة هيوستن عامله له تمثال، لما رحت أستاذ زاهر في جامعة باريس السوربون حاطط له تمثال هو وابن سينا. وأبو بكر الرازي هو the first person اللي speak about the allergic rhinitis والالرجيك ازمه، وقال انها بتيجي مع طلع الزهور، وابتدى يوصف الازمه ويوصف الاميونيتي. ايفن يعني حتى في قدماء المصريين في عندي صوره لواحد من الملوك ان جاله انافيلاكتيك شوك من انسكت بايت، وفي الرجيك ديرماتيتس، يعني مش عايز اخش في تفاصيل زياده، انما عايز اقول ان الازمه is old as man himself. وثرو ذا يير وثرو ذا هيستوري الانسيدنس اوف ازما بتزيد مع الاندسترياليزيشن، ويتقال انها ضريبه من ضرائب المدنيه due to the newcomers. لما ترجمه النيو كومرز هي المستحدثات اللي في البيئه، whether in the atmosphere او in the diet or in the home or in the working place. كل المستحدثات دي may precipitate يعني الأزمة. that is why الأزمة is increasing بالرغم من إيه better sanitation و control of the infections وكده. إنما with this asthma immunity is diminished. Usually the patient who have asthma he is more liable to infections. He is usually associated with such as with other comorbidities. يعني may have heart disease or coronary heart failure or any other maybe diabetic, and this has a reflection in the control of his asthma. فأي وبعدين البوليفارماكولوجي اللي بياخده، يعني الأدوية اللي بياخدها or the drugs he is taking may have side effects and يعني beta blockers بتاع anything may increase his asthma. لما نيجي أنا my concept للعيان الأزمة من 3 points: the patient, the disease, and the diagnosis and the management. لو جينا للعيان نفسه، يعني مش مهم الكالندر ايج، الكالندر ايج مهم، انما الكالندر ايج بيزيد with the wear and tear of life، وبيحصل aging lung. انما العيان اللي بيستهلك صحته سموكر or otherwise او في حاجه in his environment or in his house او habits او كل الكلام ده، الانسنس اوف يعني ازمه بيزيد. انا فاكر مره جمعيه نقابه الاطباء اللي في حلوان قالت لي تعالى ازمه بتزيد عندنا مش عارفين ليه، وانا جاي في السكه قلت لهم وانا جاي في السكه الشكر بقى لونه ابيض، اسمنت بتاع ترى وحلوان والمصانع اللي اتعملت من ناحيه وفي شبرا الخيمه في الناحيه والجبال جبل المقطم، فبالتالي الاير بوليوشن اشتغل. انا جات لي الفرصه ان كل رسائل الدكتوراه بتاعه المعهد البيئه بتاع عين شمس انا مشرف عليها، وعملنا كذا دكتوراه ومنهم على الازمه. وللاسف وجدنا ان الحاجات اللي موجوده في الاتموسفير whether the dust particles the pollens the ozone even، يعني واحده كانت بتشتغل في المركز القومي للبحوث لقينا انها كلها above the permissible levels في مصر. ولقينا مثلا ادي لك مثل، لما عملت الرساله دكتوراه على امبابه والوراق، لقينا امبابه هاير ليفل لان البوليوشن موجود، انما في الاوبن اتموسفير اقل. لقينا اعلى حته في مصر اللي فيها اير اوبستراكشن وفيها بيرميسيبل ليفل اللي هي ارض معروف اللي في وسط البلد عند الجماعه اللي السمكريه والكلام ده. فبالتالي البوليوشن از فيري امبورتنت. الهابتس بتاع العيان الالدرلي انديفيدوال، كتير قوي من العيانين اللي طبعا السموكينج كلنا عارفين ان ده از ان امبورتنت فاكتور، انما العيان اللي قاعد في بيته ومتعلق بكلب او بقطط، وسبيشالي القطط الشرازي او الفارسي بريسبيتيتس الازمه، بتلاقي الانسنس اوف ازمه موجوده عندهم، وصعب جدا ان العيان يتخلص من هذا. The family relation زي ما انتم عارفين قلت في مصر قوي. الالدرلي individual may be living alone in home. الفاميلي ريليشن واللي انا بسميه المسانده العائليه والمسانده المجتمعيه قلت جدا. يحطوه في بيت مسنين او يقعد في البيت لونلي، فبالتالي يعني very difficult to change his habits او يعمل كده. فلما نيجي للديزيز اتسيلف اللي بيحصل للتشينجز في الديزيز، الالاستيسيتي اوف ذا لانج بتزيد، الالاستيك ريكويل، الكومبلاينس اوف ذا لانجز، الكومبلاينس اوف ذا تشيست وير اوف ذا سباين بتديمينش، الايرلي اير واي كلوجر ايرلير بيعمل ديستنشن اوف ذا الفيورال سبيسز، وبيبقى في اير ترابنج، وممكن العيان يحصل له مودرنج، وممكن العيان يوصل لغايه لما يحصل له COPD كمان. فبالتالي يعني العيانين دول يعني عايزين اور هيلب، لان ربنا خلق كل حاجه بفلوس، الاكل بفلوس والميه بفلوس، انما الحاجه الوحيده اللي ببلاش هي الاير. فافقر مريض في الدنيا او افقر واحد في الدنيا اللي هو he cannot take the air which is permissible لإفري بني آدم أو كل كائن حي في الدنيا. وبعدين with the passage of air this individual عنده coexisting psychological و hearing trouble و other trouble. ف the communication or presence of disability عنده حاجة في مفاصله أو حاجة. These are hindering condition especially if he is living alone. فالتشينجز اللي بتحصل دي يعني is very common في الاوردرلي individual. لو جينا للاوردرلي individual مش مهم الكالندر ايج، حقيقي مهم، انما العيان اللي بيستهلك صحته بدري زي عنده رصيد في البنك وبيجي سموكر او مكان العمل بتاعه او حته بيبقى صعب يتخلص منه. انا فاكر دور واحد جاي يعمل ماجستير معايا في الحوامديه شركه السكر، افتكرنا ان حاجه موجوده في المصنع اللي بتخلي العيانين عندهم ازمه واير واي اوبستراكشن. لما بحثنا الموضوع لقينا لا، الحكايه مش كده، ده الحكايه ان من التراب والبارتكلز بتعدي النيل وبتوصل لهناك، وبالتالي بتعمل كده. وكان في لجنه في نقابه الاطباء، احنا كنا 4 الله يرحمه، السيد سالم واحمد حامد عطيه والدكتور النقيب الدكتور حمدي السيد، قالوا لنا يعني حاولوا تتغلبوا على السموكينج او حاولوا تتغلبوا على البوليوشن، قلنا لهم اعملوا هودز على المصانع بتاع الطرق وكده، ولغايه دلوقتي ده برضه ما اتعملش. فالبريسبيتيتنج والاجرافيتنج فاكتورز والبوليوشن whether it is present in the patient home or in job او his environment يعني quite difficult sometimes ان احنا نحاول نتغلب عليها لسوشيال كونديشن، لايكونوميكال كونديشن، اذا لسايكولوجيكال كونديشن دي بتبقى موجوده. لما نيجي للدياجنوزس اوف ازما في اللي هو برونكوسبيرومتري ريفرسيبيليتي، ودي كانت اول رساله دكتوراه زي ما بقول بتاعتي، ان انت بتعمل سبيرومتر وتشوف الريفرسيبيليتي. انما افرض انت ما عندكش، لان كان عنايه رسالتي كلينيكال راديولوجيكال اند سبيرومتريك، يعني ممكن اعمل كلينيكال واقدر اعرف قريب قوي من السبيرومتري، او ممكن اعمل راديولوجيكال وابقى قريب قوي من السبيرومتري. وجدنا هذا، يعني if you examine the patient وتجيب منظوره تعملها حوالين التشست، the limited excisions with the respiration, the forced expiratory time if is prolonged, if you put the cystoscope on the chest wall, a normal individual he can accentuate the vesicular breathing. انما العيان اللي عنده airway obstruction he cannot accentuate the airway the vesicular breathing اللي موجود، وبالتالي ده كلينيكالي بيقدر يقول لك sometimes there is presence of a wheeze و sometimes wheeze is not present. Even in the advanced cases the chest may be silent. لما جينا الراديولوجي كنا بنعتمد على السكرين في هذا الوقت. كنت بحط العيان السكرين في حاجه اسمها لايتنينج اب. لما العيان اللي عنده ديستندد لانج هتلاقي الرئه منوره اكتر، بيضه اكتر، لان الهواء في السكرين عكس الاكس راي، الهواء اسود في الاكس راي، في السكرين ابيض. فكنا بنقسم الاليومينيشن اوف ذا لانج بلس 1 اور بلس 2 اور 3. كل ما اللنج تبقى مور اليومينيتد كل ما العيان يبقى عنده اير واي اوبستراكشن. الموفمنت اوف ذا دايفرام هيقول لك دي بتحصل في الانفيزيما، لا، في العيان ده برضه هي كانوت موف ذا دايفرام فيري ويل. بنجيب مسطره ونقيسه وهو اندر ذا سكرين. الحقيقه لما رحت عين شمس الدكتور سيد وراي قال لي لا في حاجه تعملها زياده عن كده. قلت له ايه؟ قال شوف الموفمنت اوف ذا دايفرام، وعملناها بيبر ان ريليشن تو تايم، يعني اللي بيحرك الدايفرام 3 و4 او 2 او 3 سنتي في ثانيتين 3، مش زي اللي بيحركوا في 4 5 ثواني او 6 ثواني. فاذا كلينيكالي يو كان جيت ا فير ايديا اذا كانش عندك سبيرومتري. واحنا يمكن جالنا التشانس ان احنا في عين شمس اول عملنا اكبر معمل بتاع بالمونري فانكشن لما خدنا المنحه اللي خدناها من الدوله، وعملنا البيبرز اير واي اوبستراكشن الاف اي في 1. قعدت 17 سنه اشتغل على جدر اجهزه لدرجه كانوا عايزين ياخدوا الجهاز. ووجدنا الاف اي 1 in the Egyptians, the normal values in the Egyptian and the elderly individual، لأنه كنا بنعتمد على الجداول العالمية بتاعت الايروي اوبستراكشن بتاعت بولدوين. إنما أنا يعني عملت جداول للمصريين على إن احنا نوجد the degree of impairment أو normal values even to the Egyptian. والحقيقة جالت شانس إن بعض الزملاء بعد كده اشتغلوا الرسائل بتاعتهم. ايفن احنا واستاذنا الدكتور الجمال يعني البيك فلو ميتر او البلوك فيمتر يعني قلنا انترودكشن انا وهو انترودكشن اوف ذا بيك فلو ميتر ان ذا ايجيبشن براكتس او يس انا هخلص يعني يمكن حاجه هبطل الكلام ده وهقول كلمتين على المانجمنت. المانجمنت زي ما بقول يعني المسانده للعيانين والفورسنس اوف ذا بيشنت is is very important. طبعا any precipitating or aggravating factor should be يعني taken in consideration. وفي في المانجمنت عندنا بعض حاجات انت بتعملها. طبعا اول حاجه smoking cessation، اي حاجه موجوده in his environment، use of vaccination للعيان، any material موجوده او offending factor او precipitating و aggravating. لان الحقيقه احنا عندنا في الازمه في الإلدرلي نوعين: ازمه مبتديه في السن الصغير لونج تيرم وصلت للاولد ايج، او it started in the old age due to precipitating or aggravating factors. فهنا العيانين دول لازم تعمل respiratory exercise rehabilitation، تاخد بالك من السايكولوجيكال فاكتورز، تاخد بالك ان العيان ممكن ما يقدرش يستعمل البخاخه، هانديكابد، او بيشتغل على الاذر دراجز انتي روماتكس او كلام زي كده، تكون بريسبيتيتنج فاكتور لان يجيله تزود له الاير واي اوبستراكشن. الكلمه الاخرانيه اللي انا بطلب فيكم مساعدتها هي الاتي: يعني انا عملت شعبه من جمعيه الصدر هي الرعايه التنفسيه المنزليه. العيانين اللي بيجوا عندنا في المستشفيات اللي قدرت اعمله ان انا عملت يعني زي فيرست انتنسيف كير في مصر في الثمانينات، واللي تشرفت الجامعه لما وصلت زمان 60 سميتها باسمي. انما الرعايه التنفسيه المنزليه لما يخرج، طب العيان كبير ما بيقدرش يجي، فبنبعت ناس يروحوا له البيت، فولو اب، ممرضات، دكتور يروح. ايفن عملت نادي للمسنين في الزاويه الحمراء لما كنت رئيس نادي روتري شمال القاهره، عملنا لهم ونعمل لهم فولو اب. فيعني الفولو اب اوف ذا بيشنت از فيري امبورتنت. وان حد يزوروا البيت، يا ريت كل واحد منكم في اذا كان في مستشفى جامعي او مستشفى او مركز بتاع وزاره الصحه، ليه ما يعملش ناس من الحي عنه كنوع من المساعده؟ يعني احسن كما احسن الله اليك. والاحسان ليس بالفلوس، الاحسان بالعمل. يفحصوه، يروحوا البيت، يزوروه، ايفن يبقى طالب حتى بيبي سيتر يديله احتياجاته، اللي عنده اي جهاز انهيرر، اوكسجينيتر، اي حاجه مستغنى عنه. واحنا عاملين كنا في عين شمس واحده ست مديانا شقه، فالعيانين اللي هم اير واي اوبستراكشن اور سي او بي دي بيروحوا يعملوا لهم الفولو اب. فيا ريت كل واحد في منطقته يحاول يجمع الناس ويجمع الدكاتره اللي موجودون، الجنرال براكتيشنر. يا جماعه احنا كلكم عارفين الكلام اللي انا بقوله، كلكم اب تو ذا ليفل. انما الجنرال براكتيشنر لما عملت ستاتي اوديت اوف ازما في الايجيبشن، لقينا اغلب الدكاتره يقولوا الجنرال براكتيشنر ما يعني هيز مانجمنت اوف ازما، ويقول للعيان يا ما بلاش تستعمل البخاخه لحسن انت حالتك كذا. فبالتالي يعني الاتيتيود از كويت ديفرنت. الموضوع كبير قوي. انا التزاما بالتايم يعني بس حبيت ان يا ريت كل واحد منكم في مكان عمله، واحسن كما احسن الله لك، ويبقى عندك عطاء. وكل سنه وانتم طيبين.
ألف شكر يا أستاذ دكتور أشرف مختار. دايما أقول أشرف مذكور مش عارف ليه. دكتور مختار، إحنا بنشكرك على المعلومات القيمة اللي بتديها لنا. دكتور مختار مذكور هو أستاذنا وموسوعة في الطب، موسوعة في الطب، في الطب الحديث والقديم. أرجو يا دكتور أشرف، ودكتور أشرف مذكور هو المسؤول عن مجلة الجورنال بتاعة البرونكولوجي، ايجيبشن جورنال برونكولوجي. أرجوك يا أشرف الموسوعة بتاعة بابا لازم نكتب ونقيم الحاجات دي، وتبقى إديتوريالز في كل كوارتر ينزل. احنا عندنا المجلة 4 مرات في السنة، فأرجو إن الدكتور مختار بيه يوافق إنه كل شوية يكتب لنا حاجة من المعلومات اللي احنا بنفتقدها.
بيقول اكتب في المجله. لا، انا دلوقتي انا من 2001 بطلت اشتغل. انا بعمل 3 كتب قربت اخلصهم. واحده وده خلاص خلص ورايح للمطبعه تقريبا، تاريخ الطب في الحضاره الطبيه الاسلاميه بالعربي. واحد تاني في تاريخ الطب في الحضاره الاسلاميه بالانجليزي، لان كل حاجه الاجانب بيدعوا ان هم اللي وجدوها، بينما كلها is an Arabic contribution. والكتاب الثالث عن تاريخ الطب في الحضارة الفرعونية أو المصرية القديمة، لأن كلمة فرعونية دي غلط. الفراعنة ما جوش غير من الأوضة 18، قبل كده كانوا ملوك. فبالتالي يعني الكتب دي لما تطلع أنا هعملهم وهوزعهم إن شاء الله مجانا، وأبقى أديكوا أو أبعت لكم، ربنا يقدرني أنا أخلصهم. أصلي المشكلة كله إن أنا عندي ماكولار ديجنريشن وبستعمل فيجوال ايدز كده، ما اقدرش اقرا اي ورقه غير بدول، وجايب اجهزه من امريكا كده يعني even I cannot read what is written there. that is why ان انا بتكلم كده، والحمد لله ان يعني لان ربنا بيقول في القران ارذل العمر حتى لا يدرك بعد علم شيئا، اللي هو الاكزهايمر. لما جم يدوني الجائزه التقديريه بتاع جامعه عين شمس قلت له ما بنسميهاش اكزهايمر، انا بسميها الحياه النباتيه. ان العيان الكبير اللي بيكبر بيبقى زي الشجره، تديله ميه واكل ولا يدرك شيء. انا مش عايز اتكلم زياده اكتر.
ربنا يديك الصحه وطولة العمر يا دكتور.
لا أنا بشكر بس دعوتي للمؤتمر والهيئة المنظمة، طبعا الكل هنا، والدكتور أشرف والدكتور أحمد وطبعا دكتور طارق، يعني الكل، أستاذي الدكتور مختار مدكور. أنا سعيدة جدا إن أنا يعني شفت حضرتك وإن مع حضرتك النهاردة في السيشن. و أنا عصمت علي عبد النبي. أيوه تمام يا بيه، وكان متبادل أنا عارفة. أيوه. تمام تمام. أيوه. ت- تمام تمام دكتور محمد سليمان. أيوه. الله يبارك في حضرتك. وهو كان متبادل والله، يعني عز حضرتك قوي، وحضرتك بعد ترقية أستاذ برضو قلت له إن أنا كنت أحسن واحدة، والكلمة دي يعني أسعدتني جدا. ربنا يخلي حضرتك.
شكرا يا اسماء. دكتور احمد.
اولا بشكر الجمعيه وبشكر الدكتور اشرف حاتم استاذي، لانه له فضل كبير قوي عليا في مجال الشغل. وطبعا الدكتور طارق صفوت له معزه خاصه، هو عارف كده. طبعا الدكتور مختار استاذنا كلنا قبل كل حد. ونقفل الجلسه دلوقتي، وهندي بس الاساتذه الكرام الدكتور محمد عوض تاج الدين، والدكتور ابراهيم رضوان، الدكتور مها منى منصور، والدكتور ياسر مصطفى، الدكتور مها الخولي.
Let's start our next session. It's a general session, and it's Bronchology 1. And it's my honor and pleasure to have Professor Dr. Medhat Neg and Professor Dr. Yasser Mustafa as chairpersons with me. And our first speaker is Professor Stefano Gasparini. And Professor Gasparini is the head of Respiratory Disease Unit Department of Department of Internal Medicine and Director Specialty School in Respiratory Medicine, University Politica di Marche.
I would like, first of all, thanks all the scientific committee of the society for this kind of invitation. It's a great pleasure for me to be here. To be honest, this is the first time in my life that I am in Egypt, so I'm very happy and honored. Thank you so much. I hope that the problem will resolve soon. In any case, my talk is a history, the history of interventional pulmonology, because I think that especially young people must know what is our history and what were the pioneer that in the past developed our specialty and all the techniques that today we can use. I would like to show you in this presentation where we are coming from, where is interventional pulmonology coming from, and we are going. Well, as all the history, also this history starts with the phrase, once upon a time. Once upon a time there was a bronchial lake that is here, that was generally unknown by the inhabitants of the world. So we have to wait the 1897 to start our exploration, and the bronchoscopy and imagination begin. The merit of this procedure is by a German ear, nose, throat specialist, Gustav Kilian, everybody know it, that in 1897 was able to introduce a tube, an esophagoscope through the oral cavity into the trachea of a patient to remove a foreign body for a gentleman, a German gentleman. So the bronchoscopy begins, the exploration begins, and the name that Gustav Kilian gave to this procedure was direct bronchoscopy. So bronchoscopy born to foreign body removal. And this is still today an indication since we have still today this procedure that is done to removal foreign body. This is a needle that we removed just a few weeks ago that was accidentally inhaled. Well, I'm happy to show that, however, I'm sorry, but I'm working not in the presentation mode. So, however, Gustav Kilian was really very, very clever, because in 1898 he wrote that the practical significance of bronchoscopy cannot be assessed at that moment. And he was hoping that apart from foreign body and disease of the bronchi, this procedure, this bronchoscopy, could be useful in the future for the diagnosis and therapy of disease of the lung as well. And this is what really today happened. Well, it's strange to see that more or less in the same time, in 1910, a Sweden internist, Hans Christian Jacobaeus, started with another very important procedure for the interventional pulmonology, that is thoracoscopy. He introduced a cystoscope into the pleural cavity and was able to realize that with this technique he can explore the pleural cavity, can take biopsy from the pleura. He can remove adherents that at that time were a problem for the developing of pneumothorax. That was the only therapy for TB. Well, this is our history, and in 2015 bronchoscopy arrived in the United States thanks to Chevalier Jackson, that is considered the father of American bronchoesophagology. Chevalier Jackson developed a lot of instruments, of sampling instruments, a lot of accessories, but the main discovery that he did was to put a light at the distal end of the bronchoscope, and in this way he improved a lot the possibility to illuminate the airway. Well, I also like to remember that in 1949 there was another very important progress in bronchology thanks to an Argentine colleague. The name is Edoardo Schiepati. It sounds Italian, like a lot of people that lives in Argentina. Edoardo Schiepati was able to demonstrate that through the bronchoscope it was possible with a needle to sample lymph nodes outside the bronchial wall in the subcarina area. It was the father of transbronchial needle aspiration. Then we have a period of stop because of two world war, but we have to wait 1965 to have another very important progress that was quite casual. The colleague from the Mayo Clinic in Rochester, Minnesota, realized that pushing the forceps of the bronchoscope into the periphery, in the biopsy samples, there were also lung. Microphone, it's better. And they realized that there was lung parenchyma in their sample. So they thought maybe it's possible through the bronchoscope to sample lung and to make diagnosis of lung disease. And at that time, the transbronchial lung biopsy was born. But the technology was growing up, and the time were ready for a huge improvement of quality. In 1969, the man arrived on the moon, and what happened in our history? In our history arrived the flexible bronchoscopy that changed completely our life and our way to work. The merit of this is from Shigeto Ikeda, that you can see in this picture, from Japan. And you can see here also, this is, I am proud of this picture. This is myself 2-3 years ago, and Shigeto Ikeda in Tokyo. And you can see on the right of the slide the grave of Shigeto Ikeda. He loved bronchoscopy. And also in his grave, there is a bronchoscope, you can see on the bottom, and on the top of the grave, there is the logo of the World Association for Bronchology and Interventional Pulmonology that himself founded. So the World Association for Bronchology and Interventional Pulmonology had his Congress, the World Congress in Florence in 2016, and we were very honored to have the flag of this society for 2 years in Ancona. Next Congress will be in 2020 in Shanghai, in China. Well, go on with our history. The flexible bronchoscopy opened the way to perform a lot of accessory and ancillary procedures. For instance, the transbronchial approach to peripheral pulmonary nodule. You can see this paper where the same Ikeda is in 1967. They demonstrate that it was possible under fluoroscopic guidance to sample lesion located very peripherally into the lung parenchyma and even in the subpleural region and even in the upper lobes. And this technique is still used, as you can see here. We use it daily, the transbronchial approach to peripheral nodule. You can see here a nodule in the apex of the left bronchus that is easily approached through the bronchoscope with different kind of sample technique. Well, in 1974 arrived another very used technique. I was already working at that time. The problem is that from Ikeda I know all the people that I will show in this history, and this means that I am an old man. I just didn't know Kilian and maybe Jacobeus, but the other, I met all the others. Well, the bronchoalveolar lavage was a great illusion for all the pulmonologists. At that time, we thought that with the analysis of the liquid recovered from the lung parenchyma, we could be able to diagnose all the kind of disease of the lung. This is unfortunately not true. Bronchoalveolar lavage is an important technique, but their diagnostic role is limited just to some situation that you can see on the right side of the slide. Well, we arrived at the 80s, and what happens in the 80s in our history is the age of personal computers, and in our history there were a lot of improvement. This is Kopp and Wang. Kopp and Wang remembered Edoardo Schiappati that performed the transbronchial needle aspiration with a rigid scope and developed the technique of transbronchial needle aspiration with a flexible bronchoscope. And this was a great progress, because bronchoscopy changed completely from diagnostic technique to diagnostic and staging technique. And today, to speak about bronchoscopy without speak about staging is malpractice. But in the 80s, also the therapeutic bronchoscopy received a lot of new ideas. This is Jean-François Dumont from Marseille, France, that in 2084 published the first paper that demonstrates that the laser energy could be used to remove tissue from the bronchi, and he started to organize a lot of courses and to teach people how to reopen the airways using laser. And together with the laser, other techniques found their possibility to be used, like electrocautery, cryotherapy, and brachytherapy, to remove pathological tissue from the airway and to give the possibility to breathe to patient with the closed airway. I would like to thank my mentor in this way, that is Sergio Cavaliere from Brescia. All the pulmonologists in Italy learned to treat and to use laser and to make therapeutic bronchoscopy by Sergio, that was one of the first fellows of Jean-François Dumont. Today we can use therapeutic bronchoscopy in several conditions: treatment of early lung cancer, the treatment of airway benign tumor, of carcinoid, of malignant airway stenosis, of benign tracheobronchial stenosis, and other conditions. This is a movie that can demonstrate how the laser can be used to remove the tumor. This is a carcinoid that create complete obstruction of the left main bronchi, you can see here. Well, the technique that Jean-François Dumont, Sergio Cavaliere, and Pablo Diaz-Jimenez teach to us is, don't use laser to necrotize the lesion. Use laser to coagulate the lesion. Use laser at low power, and the laser at low power remove the vascularization of the tissue that you can see here. It become white, and when the tumor is devascularized, and so the risk of hemorrhage is reduced, you can use mechanical debulking to remove and block the tumor. And you will see here how Jean-François Dumont teached us to use the rigid bronchoscope to remove and block the global tumor and to reopen the airways. And you can see here that there is no bleeding during this maneuver because the tumor was completely devascularized using laser. Well, new technology. In 1985 arrived the videobronchoscope that was a great innovation, not only for the diagnostic point of view, because with the videoscope the quality of the image improved, but because also it allowed to introduce a lot of possibility for educational purposes, because there is the possibility to see the procedure on the monitor, the possibility to record and store the procedure. So the introduction of the video technology in bronchoscopy had a great educational impact. When I start to learn bronchoscopy, I had to put my eyes and to remove the head of the operator and to put my eyes to see what happens. And it was very difficult to learn. You are lucky. The young people today is lucky because you can see what the mentor are doing just looking at the screen. At that time, I had probably the only possibility to figure out, to imagine what he was doing, but not to see directly. So this is a great progress. In the 90s, what is the time of a handy phone? Everybody has one, everybody look at. And in our history is the time of stents. And we have to thank again Jean-François Dumont from Marseille, France, that introduced the silicone stent that are called Dumont stent, and that today are still the gold standard for the stenting the airways. When you have no tissue to remove, when you have infiltration that causes stenosis of the airway, when you have airway compression, you can use a stent to reopen the airways. But what happens about thoracoscopy? We stopped in 2010 when Jacobeus introduces this technique. Well, this technique was performed in some center in Europe. It was not performed in the United States, but in 1995, another mentor arrived in our history. He is Christian Boutin, again from Marseille, France, that developed the thoracoscopy, introduced the term of medical thoracoscopy, because this technique can be done by pulmonologists. We don't require surgeon to perform the medical thoracoscopy. And Christian Boutin wrote a lot of papers, a lot of books, and he died unfortunately some years ago. But his school is still going on thanks to his fellow, that is Philippe Pastoul, from Marseille, that will organize the World Congress of Bronchology and Interventional Pulmonology in 2022. In 1996, finally arrived the endobronchial ultrasound. Endobronchial ultrasound in bronchology. It's unbelievable. It changed completely the way to perform bronchoscopy. Today, we perform bronchoscopy in a complete different way in comparison to the past, thanks to the advent of endobronchial ultrasound. The first technology in endobronchial ultrasound was the radial probe that was introduced by Heinrich Becker from Heidelberg, and it was a balloon with a rotating probe inside that allowed to visualize 360 degrees what is outside the airway. Well, in 2000, arrived at the autofluorescence bronchoscopy that was introduced to visualize the early alteration of the airway, the early cancer, the early neoplastic lesion that maybe cannot be seen by conventional bronchoscopy. As you can see here, the red color is early cancer, is a carcinoma in situ that probably was not visualized by conventional bronchoscopy. This technique is not entered in the routine clinical practice for a lot of reasons. For instance, is not validated for adenocarcinoma that today is the most frequent histotype that we see in lung cancer. And another major limit of this technique is the very low specificity. And so this technology is still used for research and for study purposes. We arrived at 2000. Internet changed the world. And also in our history, we have something that changed our world. And this is Luis Seyo from Madrid, Spain. He had a great idea. He introduced the term of interventional pulmonology. No more thoracic endoscopy, but interventional pulmonology. This is very important because thoracic endoscopy is limitative. It means to look into the bronchi. On thoracoscopy means to look into the pleural cavity. But we don't look. We perform a lot of procedure from diagnostic and therapeutic purposes. So this terminology, interventional pulmonology, was immediately accepted by all the scientific society. For instance, the European Respiratory Society changed the name of the study group endoscopy and biopsy technique in interventional pulmonology study group. Our European Association changed its name from European Association for Bronchology in European Association for Bronchology and Interventional Pulmonology. And also the World Association did the same change in its name. It started to appear a lot of statements from the major thoracic society about interventional pulmonology, guidelines, statement on interventional pulmonology. The main reason of this, of the importance of this terminology is that interventional pulmonology emphasizes the pneumological aspect of the procedure and underlines that such procedure must be performed by physicians with competence in pulmonary disease. So interventional pulmonology is a branch of pulmonology, of general pulmonology, and must be done by pulmonologists. Well, the progress of ultrasound allowed to realize the linear probe that introduced the possibility to perform the transbronchial needle aspiration under direct ultrasound guidance. So remember, 1949, Schiapati, transbronchial needle aspiration with rigid scope. 18, Koppenwang, transbronchial needle aspiration with flexible scope. These guys were the pioneer that allowed the realization of a EBUS ultrasound, EBUS TBNA, that really changed the possibility and the performance of bronchoscopy. These are the first paper that were published about this new technology. You can see on the left side Mark Krasnick from Copenhagen, Denmark, that published the first paper on EBUS TBNA that immediately demonstrate a very, very high sensitivity, 94% of sensitivity, that is greater in comparison to the surgical technique like mediastinoscopy or video-assisted thoracic surgery. But EBUS was not useful only for mediastinal staging, but also for diagnosis of lung tumor. You can see this small nodule, 8 millimeter on the CT scan. What things. A patient come to you tomorrow with this 8 mm nodule and ask you, doctor, what can I do? And what is your answer? Well, look at the CT scan. Very close to the small nodule, there is a small bronchus. It's 4 mm. Is enough to receive the tip of the echobronchoscope. And if I wedge the echobronchoscope in this small bronchus, I can see very well the nodule you can see on the slide, and I can sample the nodule very easily. And it was a metastasis from urinary tract cancer. And you can see here the needle that enter in the 8 mm nodule, and diagnosis was done. The progress ran very fast. In 2000, we have the satellite navigational system. Everybody on their car has a GPS. Well, also in the bronchoscopy arrived the electromagnetic navigation, the possibility to visualize the probe inside the tracheobronchial tree through an electromagnetic field that is done around the patient. This navigation system allows us to move the probe inside the bronchi and to reach peripheral lesion very easily. The position of the probe is projected on the CT scan, that is the map, our road map, where we are moving and where we are driving. Well, another very interesting technology developed by my friend Luc Tiberville, that is also a very nice drum player from Rouen, France, in the confocal fluorescence endomicroscopy. We can introduce a probe into the peripheral airway that with a laser system and the confocal microscopy system is able to enlarge and to give a live, real vision of very, very small structure. You can see in this movie the alveoli of this patient, and this small spot that you see moving into the alveoli are macrophage. This guy was affected by smoking-related respiratory bronchiolitis, the squamative interstitial pneumonia, and you can feel live in a human subject the alveoli wall, the elastic wall of the alveoli that are filled by macrophages that are moving into the alveolar space. And we arrive at today. What yesterday, today, what happens today? As you can see, the way to perform bronchoscopy has changed. This is Kilian, and this is our modern bronchoscopic suite equipped with a lot of technology. Today, interventional pulmonology learned to move through the esophagus, not to remove work from the gastroenterologist, but because the esophagus is a thoracic structure and it allows to perform a lot of procedure into the thoracic structure like lymph nodes, like lung parenchyma, and to stage lung cancer is another great way. This is Bing Wambu from Seoul, Korea, that in 2009 published this paper, and where she said, hey guys, pulmonologists, we can introduce our echobronchoscope into the esophagus, and this could be a great advantage. The esophagus is a new way for interventional pulmonology. We can sample lung lesion, like in this case. You can see the echobronchoscope that is in the esophagus, and through this way we can sample this pulmonary consolidation that is very close to the esophageal wall. Well, today we can go farther with the echobronchoscope into the esophagus, we can also sample left adrenal glands metastasis. We can sample liver metastasis. The bronchoscope is going behind the thorax, and this is the title of an editorial that we had the luck to wrote on respiration some years ago. 2009, cryobiopsy. This is a hot topic. We are discussing a lot in the scientific community about the value of cryobiopsy, and this is Jürg Etzel that wrote first this paper in 2009 with my friend Venerino Poletti, that is very active in this field, that published a lot of paper to demonstrate that cryobiopsy can give a very, very nice piece of tissue, introducing the cryoprobe into the periphery of the lung, and freezing the cryoprobe, you can remove 1 centimeter and more of pulmonary tissue. And these samples allow us to perform diagnosis also of very difficult to diagnose interstitial lung disease like idiopathic pulmonary fibrosis that before was considered not diagnosticable using bronchoscopy, and it required surgical specimen. Emphysema and asthma. This is completely new topic. When I start to perform bronchoscopy, severe emphysema and asthma were contraindication for bronchoscopy. Today, we changed our bronchoscopic suite in hardware store, and we are talking about valves, sealant, coils, steam, bronchial thermoplastic. So we not only perform bronchoscopy in these pathologies, but we perform bronchoscopy to treat severe emphysema and asthma. Look at this woman. This woman had severe emphysema. You can see on the left side that there is a huge hyperinflation of the left lung that moved the mediastinal line. Well, we put two valves. One large valve in the left lower lobe that was the most affected by emphysema. And with this very easy procedure, this is the valve, and you can see that the valves allow the air to go out from the lung, but avoid the air to enter into the lung. And you can see on the left, on the right side of the slide, I will move this the complete atelectasis of the left lower lobe, and the mediastinum returned in the middle, and you can see the huge improvement of the pulmonary function here. It would be never reached using drugs or using pharmaceutical therapy. And also coils is another system, but this is not the moment to go deeper into this technique. This is thermoplastic for the treatment of asthma. I don't speak about this topic because I just would like to show you where we are going and what we reach with this interventional pulmonology. And the future, what we will expect from the future. New technologies, of course. We have new optical technology for diagnosis in situ without the need for excisional biopsy. For instance, the optical coherence tomography system that can allow us to reach a resolution that is quite similar to histology. You can see the histology on the top and the optical coherence tomography on the bottom, and you can see that we can see the cilia, we can see the epithelial cell, we can see the glands, we can see the muscle, we can see the basal membrane, we can see all the structure in vivo without excisional biopsy. The new progress for stent, but Lutz Freitag will talk after me about this topic. He's a mentor about this topic, and you will hear a lot of interesting thing about the progress on stenting. New navigation system, the possibility to treat peripheral tumor with our bronchoscope, microwave, radiofrequency ablation. New technology are coming. I was a couple of years ago in the United States, and I had the possibility to look this treatment of an experimental tumor produced in an animal, and you can see that using a probe, that a microwave probe, we can burn the tissue and we can remove the tumor. So figure out, the patient arriving in your service with a nodule is not surgical because of age, because of comorbidities, and this is very frequent in our practice. So we perform bronchoscopy, we diagnose the tumor using ROSE, and we don't move the bronchoscope for the patient. We introduce the probe with microwave, we burn the tumor, we diagnose and we treat the tumor in 2 hours in outpatient setting. This is the future of our specialty, and I'm sure that in the next year, everybody could be able to do this. New navigation system arriving, and this is very interesting navigation system that allows the possibility to navigate into the bronchi, but also the possibility to navigate with percutaneous approach to the nodule. This is a navigation that is connected to the needle, and we can see the needle on the screen, we can see the needle projected on the reconstruction that you have with CT scan. And again, a new progress. The patient is coming in your unit, you perform bronchoscopy, you perform the transbronchial approach to peripheral nodule because you have less risk of pneumothorax. You look at the ROSE says, not diagnostic, well, don't move the patient, perform percutaneous approach without need of CT scan, without need of radiologist. But I'm sure that the future of the guidance technique will be Con-Beam CT. Con-Beam CT is used already by interventional radiologists, by interventional cardiology, and it will be the future of the technical guide system. It will allow to have three-dimensional fluoroscopic view, to have a CT scan view on real time of the lesion, of the position of our sampling instrument. So probably in the future also interventional pulmonology will use this technology. What is the last arrive? The last arrive is the robotic bronchoscopy. That is a very interesting and exciting technology, and is especially very useful for young people that use it to play with joystick to video game. And the young people will perform bronchoscopy in the future without touching the bronchoscope, just using the joystick. Like a video game, and they could move the bronchoscope that is very flexible, and with the guidance system using a joystick, as you can see on the left side, we can arrive on very, very peripheral and distal lesions, and you will see how this instrument is able to bend the tip and to provide the possibility to perform biopsy in very angulated and very small bronchi. You can see the probe that reached the nodule, always moved and controlled with the joystick, and with the probe will arrive to the lesion, and we can control the movement using whatever guidance system you want, and also combine CT. Look the possibility to bend the tip, to move the bronchi, and to insert an instrument, sampling instrument into the lesion at different levels. So this is not the future, this is already used in some center in the United States. I don't know in Europe, but I don't think that is still yet arrived in Europe. Well, I close my history remembering one very important thing. All the technology that you have seen have been realized thanks to the passion of pioneer, of colleague that lost a lot of time, a lot of days, a lot of years to study and to work hardly. Interventional pulmonology doesn't make rich men. So you need to have passion to go on, and I'm sure that the young pulmonologists will have a passion to make further progresses in the future, developing further interventional pulmonology technique. Thank you very much.
Thank you, Professor Stefano, for your very good journey. You take it from Rome to Cairo, to all over the world, from Japan, from France, from USA. It's a very good journey to us, and thank you very much for very illustrative and selective photos and references about this technology. Thank you very much, and hope we can, all of us, enjoy this journey from you. Now I can introduce my colleagues, Professor Tariq Safat, Professor of Chest Diseases in Shams University. And first of all, I would like to thank all the members of Bronchology Society for inviting me to attend this conference. I hope a very good, successful conference for your society, Professor Tariq. And now he will tell us about the interventional pulmonology in Egypt.
Okay, so good morning. And I'm just gonna cover, of course, after the fascinating presentation of Professor Gasparini, which we really enjoyed his being our guest, I'm just gonna give our experience in intervention bronchoscopy in Egypt and the milestones of this, the bronchoscopy in our country. So if you're talking about the early years, we were all used to use the rigid scopes for foreign body removals, and then we went into the flexible scopes in the early 70s. And after that, we went into the, it was a kind of curiosity at that time, why are you using the flexible bronchoscopy? And the surgeons were more towards the rigid bronchoscopy. And later in the 90s, resurrection of the rigid bronchoscopes, the rigid, we started to move, especially with the introduction of electro and laser techniques. And as Professor Gasparini has showed for us, what's the future, the robotic diagnostic and therapeutic technology. And let me put a point here. Are we going really, as clinicians, work in robotic, in this, or all the robots will gonna take over? I think in the future we'll be behind the desk and the robots will function, and we're gonna see what's going on. So the historical background, I'm gonna just cover the historical background, the national research. I'm gonna go just highlighting what's happening and what's the research and what's the papers in different centers covering from Upper to Lower Egypt, and some diagnostic procedures. Rigid bronchoscopy in Egypt was introduced in the late 50s and actually declined in 70s and 80s after the introduction of the fiber optic bronchoscopy. And then it was reintroduced in the early 90s when we introduced in the departments the laser application and electro. And in flexible bronchoscopy was introduced for the first time in Egypt at Ain Shams University in '72. This is my mentor. Unfortunately, he passed away in 2012, and we learned a lot from Professor Hassan Hosni. He introduced the first flexible bronchoscopy in '72, and then he introduced as well in the early '90s the laser bronchoscopy, and from that time we started working aggressively and vigorously on regiscopes. And further on, we founded the Society of Bronchology in 2001, and a journal of bronchology, which is published quarterly from 2007, and many papers of bronchology actually were published in this journal. So let's talk about the bronchoscopy. One of the first editorial in the journal was written by Professor Henry Colt. He's a dear friend of us. And we surveyed at that time how many bronchoscopists are in Egypt. Actually, there were 87. Units were about 16. Total number of bronchoscopy in 2007 was about 6,000 bronchoscopy. Male to female ratio of bronchoscopy, males were more. And then 28 to 63% were performing TBNAs or transbronchial biopsies. And complication rate actually were very, very low. We had a paper, which is a paper was published from Ain Shams University. And we were a group of co-authors in it, and it was just for 500 procedures, over 255 patients, just to compare the laser with the electrocautery. And actually, the complications or the comparison were more or less equivocal between the electro and laser. Actually, we're more towards the electro. We used to have 2 equipments in our facility at Ain Shams, but now we prefer the electro as it's much less expensive and it's affordable. The laser has been a little bit more expensive. By the way, the majority of our patients are paying out of their pocket. So that's the point. That was a before and after laser resection. Before and after, that's an X-ray. Sorry for the quality. Before and after debulking with the laser. And we introduced the stents as well in our practice, and the most popular stent we're using is the Gimon stent. It's still affordable. I think each stent will cost from $200 to $300 US, so it is affordable compared to other stents. Cryotherapy has been introduced as well in the early 90s or in the 2000s as well. It's being applied with the cryobiopsies, etc. Another paper as well, just to highlight what the activities we're doing. Interventional bronchoscopy in the initial management of benign and malignant tracheal stenosis. Actually, we face a lot of tracheal stenosis, especially after mechanical ventilation. We get webs and sometimes bottleneck obstruction. We have sometimes tracheal tumors. So this was a useful option in the management of benign and inoperable complex benign and malignant stenosis. And this was the major author, the main author was Ashraf Madkour, and he's with us today. And this is what we're doing, debulking and with the electro, and then introducing a stent. We deploy the stent. And actually, it's a good piece of work that we're doing at Ain Shams University. In Mansoura, that's in Lower Egypt center, and they are very as well active, and they are doing the sequential use of cryo-extraction with the cryobiopsies post-electrocautery for airway recanalization using fiber optic bronchoscopy. That was a paper published in the Bronchology journal. and showing the before and after electro and then cryo extraction, which is really a good tool to extract and debulk some of the tumors. Another paper at Ain Shams as well, electrocautery and cryotherapy in inoperable malignant lung lesion, and published in the Bronchology journal, and it showed as well the results and the practice of debulking with these two procedures. At Monofia, that's another Lower Egypt, one of the major centers, university, they have as well published the cryo and electrocautery in the management of malignant endobronchial neoplasms. And actually, they didn't show that there's any significant difference between the two groups, and that it was performed under local anesthesia. That's some of the slides showing the tumor and the management with the debulking procedure and the cryobiopsy, etc. That's another paper as well of fiber optic bronchoscopy cryo for endobronchial lung cancer at Monofea as well, and published in the Egyptian Journal of Chest Disease and Tuberculosis. So we have actually a lot of practice in electro and cryo in our country, in Egypt. This was a paper at the presented at the European Respiratory Society at the annual Congress in 2012. And this was from the Asyut University, showing the intervention bronchoscopy treatment which improves the quality of life in patients with advanced bronchial constriction. Definitely, we totally appreciate this, that really a lot of patients, they improve and the quality of life improves when we debulk the big tumors from the major airways. Another paper from Ain Shams as well, evaluation of bronchoscopic placement of tracheobronchial silicone stents at Ain Shams University Hospital experience, and by Professor Ahmad Orra, Ashraf Matkour, and Khalid Wagi, which are present with us today. And it was the placement of Dumont silicone tracheal bronchial stent, which was really applied and easily applied and effective with no life-threatening stent-related complications during the management. However, we needed to perform a lot of bronchial toilette, 2-3 months to clear the mucus and the mucus blanket which happens after the deployment of the stents. So we need to perform bronchial toilettes, etc. This is the same paper. Foreign bodies, we have a lot of problems with the foreign bodies, especially with the veiled ladies putting the pin in the veil, and lot of papers are just to show here, more than 14 papers. That these were the one we could get, but I think we have more than that. And actually, my colleague Ashraf Matkour is going to present tomorrow the Egyptian experience in airway foreign body retrieval, which was really interesting how he performed, and with his the co-authors of this paper, to retrieve the foreign body from the lower airways. So what was interesting as well, the treatment, the intratumoral, one of the papers as well, which was quite interesting, the efficacy of bronchoscopic intratumoral chemotherapy in palliation of inoperable lung cancer. And that was in MDCs at Ain Shams in 2011. I had the privilege to supervise it with a group of Professor Ahmad Orra, Ashraf Matkour, and Dr. Tamer Ali, Hisham Al-Ghazali. And we injected the cisplatin 20 ml for the patients, and it showed a significant improvement in dyspnea score, and there was definitely reduction in the size of the opening, and it improved the tumor size and the quality of life as well of the patient. This is the method of insertion of the needle, either vertically or oblique angle, or perpendicular, and we insert the needle into the tumor, of course, with the fluoroscopic guidance, and we inject the chemotherapy, and it showed quite a good improvement. This is before and after. Sorry for the quality of the picture, but it shows the total obstruction and then the opening of the segment after the injection of the cisplatinum. Another paper by the Mansoura group, which was the injection, endobronchial tumor injection and debulking with the ethanol injection, and it showed as well a good result, which was effective and safe, with, of course, with the adjuvant treatment with the chemotherapy. And this shows the lesion before and then after the injection, and here there was opening of the lesion and inflation of the left lung. Percutaneous tracheostomy was performed as well. One of the papers which was realized in the fiber optic guided percutaneous tracheostomy, and it showed that was published in the Bronchology journal, and this was a nice paper as well for tracheostomy. Endobronchial ultrasound directed TBNAs in diagnosis of mediastinal lesions. That was an initial Egyptian experience from Ain Shams University, and which shows a sensitivity of more than about 90% and specificity of 100%, and distinguishing between the benign from malignant mediastinal lesions. That's the EBUS. We used the radial one, the different pictures. One of the papers in this paper, which was in collaboration with the Japanese group, that was from the Asyut University by Professor Sharif Muhammad, of the epidermal growth factor mutation, and was published in the Chest 2007. And that was a really nice piece of work as well. That's what some of the slides. The convex probe endobronchial ultrasound guided TBNAs in the diagnosis of hilar mediastinal lesions, that was used as well, and that was a group from Ain Shams University and published in the Bronchology journal. And it is a minimally invasive, safe, and really still underutilized, but still underutilized. We don't have a lot of convex probe bronchoscopes. We still use more the radial, but some of the centers have the convex probe real-time ultrasonography. ROSE, the value of rapid on-site evaluation during endobronchial ultrasound guided TBNAs in diagnosis of mediastinal, that was another paper, and it has an advantage with the EBUS TBNA in many aspects. And that was a paper from Tanta University, and one of the major authors were Professor Hantira, and that was a real nice piece of work as well. The role of endobronchial ultrasound elastography in the diagnosis of mediastinal lymph nodes from Tanta University as well, and one of the co-authors was Professor Hantira, and he showed that elastography is a very helpful tool for diagnosing mediastinal lymph nodes with a strain ratio above 7.5, having a strong suggestion of malignancy, and was published in the journal Bronchology in 2017. That was some of the pictures. And from Cairo University, the comparison between the ultrasound-guided EcoTip HD22G needle versus the EcoTip Pro 22 gauge needle in diagnosis of mediastinal lesions, and which was published in the, it's under publication actually, and it showed that both needles can be used equally in sampling mediastinal lesions. Autofluorescence actually was introduced in Egypt in the early this millennium, 2001 and 2002, and it was the major aim was for the early detection of lung cancer. We had many papers done on this equipment, and one of these papers was the addition of endobronchial ultrasound, which improved the classification of suspicion lesions detected by autofluorescence bronchoscopy, and it helped in early detection, of course, with the help of EBIS as well. For combining the the autofluorescence with the EBIS, it provided a reliable method of staging and choice of treatment modality of lung cancer. One of the very active doctors in the field of pulmonology as well has done a usefulness of bronchoscopic probe-based confocal laser endomicroscopy in the diagnosis of pneumocystitis jirovecii pneumonia, and this was a work with the Spanish group. Her name is Hannah Shafiq, and it showed that it is a quick and safe procedure for on-site diagnosis for patients having this pneumocystis pneumonia, and with excellent specificity and sensitivity in smokers, and this was published in the Respiration in 2016. And this shows the difference of pictures, the left and the right, and the normal one, the C. And this is one of the nice work and papers on confocal laser endomicroscopy in the diagnosis of this kind of pneumocystis pneumonia. She had as well, Alexandria has another paper as well on narrowband imaging, comparing the narrowband imaging with the white light bronchoscopy in diagnosing some bronchopulmonary diseases. And it was quite interesting to show the difference in the images. And they had as well, the Alexandria group have a paper on the image-enhanced bronchoscopic evaluation of bronchial mucosa microvasculature in COPD. And the conclusion of this work, which was published actually in, that was a paper, I don't know where it's from, anyhow, the conclusion that the combined the white light bronchoscopy with the eye scan seems to be valuable in evaluating mucosal microvasculature and surface changes in COPD, which may represent vasodilatation rather than angiogenesis. That's some of the pictures. Just for the sake of time, I have to. Transbronchial cryobiopsy is a new tool for lung biopsies in diagnosis of interstitial lung disease from the group of Cairo University, and it showed that transbronchial cryobiopsy is a novel technique which allows to obtain large biopsies sample of lung parenchyma that exceed the size and quality of forceps biopsy sample, it's under publication, and it shows the value of cryobiopsy in those. That's the last slide, and this is our old facility in Ain Shams University. That's the 4 Musketeers. I think we're missing Khalid Wagi as well, and Professor Nihad Osman and Professor Mariam. So Professor Yasser Mustafa is our chairman, and he's gonna improve all this facility in the coming this year. So congratulations for our new equipment, Yasser, and thank you very much for your attention.
Thank you very much, my professor, dear Professor Dr. Tariq Safwat, and the real boss and chairman. Any questions? For sake of time, it is my pleasure to introduce the chairpersons in the next session, which is about fungal infection and non-tuberculous mycobacterial disease. May I introduce Professor Ahmed Abu Nagla, interstitial lung disease, Professor Ahmed Al-Badawi, Professor Ayman Omar, Professor Ahmed Koraa, Professor Mohammed Siddiqui, and Professor Randa Salah.